All right, so during this course, we will talk about ECG. So ECG is really very important topic that is very complicated as well, that every medical student, doctors, nurses, and physician assistants should understand in order to help diagnose patients with different diseases using the ECG. Now, before starting with ECG, we will start step by step. We will go through the fundamentals and the basic knowledge of ECG. And after that, we will go to advancement in ECG and how to diagnose diseases using this this powerful diagnostic test. Now, before starting with ECG, we should understand that ECG is only a test that should be interpreted in clinical context. So we need to know the patient history and physical examination before diagnosing patient with certain pathology depending on ECG. So it is just like any other lab, just like CPC or renal chemistry, for example. ECG will give you information. It will not give you the whole picture, but will help you reaching a diagnosis that you are interested in. Now, before we start, we should know what is ECG. So when we are talking about ECG, it's called electrocardiogram. Three parts of the word, which is electro, that means electricity. Cardio means cardiac, which is the heart. Gram is drawing or the picture. So it's simply a picture of the electricity that is generated by the heart muscle. So it is simply the recording of electrical impulses that are generated by the heart. The heart muscle, when it contracts, it contracts by the action of an electricity. This electricity is coming from something called SA node or sinoatrial node. From its name, it's located in the atrium. So it's called sinoatrial node. All right, we will talk about this more in details. So electrocardiogram, again, is a recording of electrical impulses that are generated by the heart. Now, if in physics, we have some basic fundamentals and principal rules we should know before start reading ECGs. In order to record any electrical potential, you need 2 points. You always take 2 points, and the electrical potential is the difference between these two points. So whenever we are looking at the ECG, we have to determine 2 points, okay? Now, my other rule that is really important, earth potential is always 0. It is our reference, is the earth, okay? So if you want to know the potential at a specific point at the body, okay? So you need another point, right? So your next point will be the earth. The earth will be always your second point because it is 0, so it will not affect the potential of the first node, the first point. Okay, so this is important. I will show you a picture about this. Now, the third rule that we need is, by convention, if electricity is traveling toward a point of interest, then if you record that potential at that point, the electricity is coming toward it, right? The wave should be positive. Okay, this is by convention. This is how scientists applies rules on physics. They just, by convention, they wanted to have this rule that if electricity is approaching a point, you should draw this wave as a positive deflection. Now, if the electricity is moving away from a point, then the wave will be in negative. So again, if we want to take a picture of this, look here. If there is an electricity that is approaching a point here, okay, so if you want to have a drawing of the schematic diagram, it will be a positive deflection. Now, if the electricity is going away from this point, as we see here, then the wave will be a negative deflection like this. Okay, this will help us understand why some waves in the EKG will be positive and other waves will be negative. Okay, we will talk about this later. Now, in order to understand EKG, you should understand first electricity impulses and how they travel on the heart. Let's remember this together. We remember that we have a right atrium and we have a left atrium. and there's the right ventricle and left ventricle. Look here, the muscle bulk of the ventricles. Ventricles are always larger than atrium, and the left ventricle is actually larger than the right ventricle. Okay, this is important in mind. Just to keep this in mind. Why? Because when we are recording the electricity that is coming from the left ventricle, I suppose that these impulses will be larger in amplitude. The potential will be greater. But if we take the electricity that is coming from the right ventricle, we suppose that the amplitude of this electricity or the amount of this electricity will be lower. And if we record the electricity that is coming from the atrium is very thin. There is no muscle there, very thin muscle. So if we are recording the electricity of the atrium, the voltage or the potential of this electricity will be much lower than the right ventricle. This is really very important as well. When we see cases of right ventricular hypertrophy, for example, we will see that the electricity that is coming from the right ventricle is much larger and the amount is much more than the left ventricle, indicating that the muscle itself of the right ventricle is getting bigger. So just keep that in mind. Now, what is the normal electrical impulse? So we have something called sinoatrial node. If you can see, where is it? It's in the right atrium, just at the junction with the superior vena cava. This is the superior vena cava. Okay, so it generates electricity. This electricity will travel through the atrium very fast. So now the atrium will contract. Okay, so the atrium, both atrium will contract. Now, if I will ask you a question here, which atrium will contract first? The answer is much easy. It's very easy. It's the right atrium. The right atrium will contract first because electricity is generated in the right atrium. So we suspect that we will see that during EKG recording, right atrium impulse is the first impulse that we get. Okay, so right atrium will contract, and after that, left atrium will contract. Okay, and after that, if you see, guys, here, there is another node called atrioventricular node. From its name, implies it is between the atrium and the ventricle, atrioventricular. What is the function of this node? It's simply delaying the electricity. It will hold the electricity by itself, delaying it a little bit to give enough time for the atrium to contract, and after that will pass this electricity to the ventricles. Now, my question is, why not this electricity just go directly to the ventricles from the muscle here? The answer is very simple, because we have in anatomy, we have something called fibroelastic cartilage. There is a cartilaginous plate that separates the atrium from the ventricle, and this is as it acts as insulator. So electricity from the atrium will not go to the ventricle. So any electricity that should pass to the ventricle should come from a muscle. And if we can see here in this plate, the fibroelastic plate, there is only a single opening that permit some muscle fiber to come from the atrium to the ventricles. Okay, so what happens here? Normally speaking, physiologically speaking, the AV node or the atrioventricular node will hold the electricity. After a few moments, this electricity will travel through a specialized muscle fiber. This muscle fiber is called bundle of Hess or Hess bundle. Okay? Please note that this is not nerve. It is a muscle tissue that is specialized in conducting electricity. There is no nerves in the heart. All right. So the electricity will come from at AV node to bundle of Hess. And after that, bundle of Hess will give me two branches. One branch will go to the left ventricle, and the other bundle will go to the right ventricle. So the names are very easy, right? The left bundle branch and the right bundle branch. Now, if you look at the left bundle branch, because the left ventricle is really very large, this branch should also subdivide into multiple branches. There are two main branches. One branch goes to the anterior wall of the ventricle, that is called left anterior fascicle, and other branch that goes to the posterior part of the left ventricle that is called left posterior fascicle. So the left bundle branch will divide into two fascicles, the left anterior and left posterior. The right branch does not do that. It will be one main branch going to the right ventricle. Why? Simply because the right ventricle muscle is less than, the bulk of it is less than the left ventricle. Okay. After that, all these branches will now give me small fibers that will infiltrate the muscle. These small fibers are called Purkinje fibers. Those Purkinje fibers will make sure that all the electricity will go everywhere in the heart, so the heart will contract smoothly. All right. So we now understand the electricity of the heart. My next point is, now let's apply the physics rules that we learned from the first slide here. Let's see. Let me just get the color that I want here. Okay, perfect, the pen. Okay, let's see here. All right, guys. So let's record. So the heart is here. Okay, the heart is approximately like this. All right, so the heart will generate this electricity, and we want to capture this electricity. Now, during early invention of EKG, it was very simple because we have one rule that the physicists understand very well at that time, that if we want to record an action potential or electrical potential, we need 2 points. So what they did, they put a lead at the right arm and another lead or electrode at the left arm, and they connected them together. Okay, this is called lead 1. Okay, so what is lead 1? It is the difference between the potential of the right arm and the left arm. It's called lead 1. Now, what does lead 1 implies? If you look here, guys, you will see that lead 1 is just above the heart, right? Just above the heart. So as if you are looking at the heart, the electricity of the heart from above. Okay, so lead 1 is above the heart, as you see in this picture, and is looking to the heart from down. Okay, so the heart will be under lead 1. This is important. Again, we will understand more when we see the waves. We will understand this more. Okay, now another lead or electrode was put on the left leg. Okay, and now we have these connections. If we connected the left arm with the left leg, we have the third lead or lead 3. Okay, and if we connected the right arm with the left leg, now we have lead 2. If you note here that lead 2 and lead 3 are looking to the heart from below, so they are inferior leads. Okay, so we have now 3 lamp leads. We have lead 1 that is looking at the heart from above, and we have lead 2 and 3 that are looking to the heart from below. This is important. After a while, like a few years of getting this EKG, another scientist came and he said, like, okay, let's put another lead on the right lower extremity here, another lead. And this lead will be connected to the earth. Okay, by the ECG machine itself will connect this lead to the earth. So the potential here will be 0, right? Because earth potential is 0. Okay, and from this point, a very important principle arises. What is the principle? Now, if we get this point here, which is the right arm, okay? If we get the principle of the right arm here, the right arm will simply, okay, the right arm here, right arm, okay? And we connected it with this lead here. So this lead is 0, right? So when you connected them both, that means that as if you are recording the electricity only from the right arm, because the potential at the right lower limb here is 0. So it will be neglected, okay? At this, by using this mechanism, now you are able to record only the potential at the right arm. And this will be called VR. Okay, VR. V means like a vector, and R means right. So there is a potential here that we can look at the heart from the right side, as you can see. So the AVR or VR looks at the heart from the right side. Now, VR sometimes called AVR. We add a small a here. What does A mean? A means augmented. Augmented means that the electrical potential is more augmented by the amplitude by using a certain formula that we don't need to go through. Okay, so the device itself will write the waves, will draw the waves larger than the actual wave. Okay, by a certain formula, we don't need to go through it. All right, so VR or AVR is the limb lead that is looking to the heart from the right side. Now, the same thing can be applied to the left arm. If we connected this left arm to the right leg again is 0, so it will be neglected. So as if you are recording the potential only from the left arm, and you are looking to the heart from the left side, right? So this is what called VL or AVL. All right. And the same thing will be applied to the lower limb here, the left leg. The left leg will be connected with this 0 potential, which is neglected. So we are looking at the heart from below here, and it's called AVF, and F stands for inferior. Okay, so for now, we have 6 limb leads. Lead 1, looking to the heart from above. Lead 2 and 3, looking from the heart to the heart from below. AVR, looking to the heart from the right side. AVL, looking to the heart from the left side. And AVF, looking at the heart from the down, okay, or inferiorly. Okay. Now, this was the EKG. And after a few years after this invention, a new scientist came and he said, okay, let's look at the heart anteriorly. Okay, let's put some leads that looks to the heart from in front, from here. I want to look to the heart here. So he invented a new leads that's called chest or precordial leads. Okay, precordial mean chest. Okay, like they are on the anterior chest wall. So what are these leads? Simply, they are electrodes that will be placed on the anterior wall of the chest and will be connected with this earthing potential that is 0. So I will look at the heart from this specific point anteriorly. Okay, how many leads we have precordial? Again, we have 6 leads. So we have 6 limb leads and we have 6 precordial leads. So we are looking at the heart from 12 different points. Okay, now let's take another picture to see this appropriately. Okay, if you look here, so how we place them? So they are 6 leads. Okay, placing them is really very important. In order to place them on in your real patient, you have to palpate xiphoesternal joint. Xiphoesternal joint is very easy to palpate. Just put your hand, your fingers, palpate the sternum. You will find like a notch. This is called xiphoesternal joint. Xiphoesternal joint is at the level of rib number 2. Okay, the subcostal space or intercostal space between below rib 2 is called intercostal space number 2. So you palpate the next space, that is number 3. And you go down for the number 4, intercostal space number 4. In the intercostal number 4, you put your first lead to the right side and the second lead to the left side. So you have V1 and V2. Please note that V1 and V2 are looking to the heart directly at the septum. If you can see, the septum is here. Okay, so V1 and V2 are looking directly to the septum. So if anything happens to the septum, V1 and V2 will look at the septum and they will change. This is important. Now, after that, what I do, we usually ignore V3. We don't put it here. We go to V4. Where should I put the V4? I go to intercostal space number 5. At the mid-clavicular line from the clavicle, I draw a line in the middle of it and put V4. Okay. and I go back to V3. So V3 should be placed between V2 and V4. Okay, so it's easy. It's easy to be put, right? So V4 is it has a landmark. It should be in the fifth intercostal space at the left, at the midclavicular line. And V3 will be in between V2 and V4. Now, please note that V3 and V4 are looking to the bulk of the left atrium, left ventricle, sorry. Okay, so they are looking anteriorly. All right. And after that, you put V6 before V5. V6, you go with the armpit. You see a mid-axillary line in the armpit. And you go to the intercostal space number 5, and you put V6. And V5 will be between V4 and V6. Please note that V5 and V6 are looking to the heart from lateral wall, just like the AVL. Okay, so we have 3 leads that are looking at the lateral wall. We have AVL, V5, and V6. And we have 3 leads that are looking to the heart from inferior. They are lead 3 and lead 2 and AVF. Okay, this is really important. We have to understand this. When we interpret EKG, this will help us. Now, this is a real patient with this drawing. Now, please note that this is the right arm, right? Now, you have to place AVR on the right arm. You can place it here, distally, or proximally, or very proximally. It does not matter. And actually, if it is very proximal, it's much better because the electricity is generated from the heart. And when it travels further, it will be weaker as a signal. So you need it very proximal. So we put AVR here. Now, the same thing will be applied to the AVL. So you can plot it here, 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 or even very proximal here. It's the work. Now, for the left lower extremity, you can put it very down at the foot or ankle or in the thigh, and you can put it here, and it will work. And for the earthing one, the same applies. You can apply it to the right leg, wherever you want, but the proximal is better. Okay, so this is earthing, this is 0. The device itself, the EKG machine, will determine that is 0 by default. Okay, so you don't worry about that. And after that, you put like V1 and V2, very easy. Again, you palpate the xiphisternal joint. Okay, mandibular sternal joint, sorry. And this will be at the level of the second rep. This is the second intercostal. You go third intercostal and fourth intercostal. To the right side, you put V1. To the left side, you put V2. And after that, you miss V3. You go with V4, and you draw a line from the clavicle, midclavicular line, to the fifth intercostal space, and you put your V4. And in between, V3 should be here, but I think it's detached. It should be here. Okay, and after that, you go with V6, with the mid-axillary line, you draw it, and you put it in the fifth intercostal space, and V5 will be in between V4 and V6. All right, so this is how you place your leads. All right, now let's talk about the EKG machine itself. EKG machine is pre-programmed. It's pre-programmed to a certain speed and certain sensitivity. We will talk about this now. But before talking about this, I love to talk about the paper itself. Paper itself is thermal recording paper. That means the ECG machine does not use ink. It only has a needle, and this needle will be heated. And by this heat, the drawing will occur. Just remember the receipts you are taking from when you buy something, you will get the receipt. The receipt is a thermal recording paper. That means if you apply some heat to it, it will turn black. Okay, the same thing applies to the EKG. Now, during recording of the EKG, you should ask the patient to hold his breath or her breath. Why? Because when patient is breathing, the diaphragm and the muscles, intercostal muscles, are contracting, and they are muscles contracting by the action of electricity. This electricity will just disturb your heart electricity, and the EKG will just give you unnecessary waves that you can't interpret. Okay, so if patient is awake, you should ask him or her to hold him or his or her breath. Perfect. Now, let's talk about the paper itself. So the paper itself is very easy to understand, and you should understand this very clearly. So if you look at the paper, the EKG paper, it consists of small squares. Each small square is 1 millimeter length and width and 1 millimeter in length. Okay, so it's 1 by 1 millimeter. Now, the large square consists of 5 squares by 5 squares. So there are 25 squares, small squares in a large square. Okay, now this is important because if I want to ask you about the length of the large square, it will be easy for you. It will be 5 millimeters, right? And the height of this square will be also 5 millimeters because it consists of 5 squares by 5 squares. All right, this is really very important. Now, I have another thing that is called paper speed. So the paper will just be ejected from the device in a certain speed, and the standard speed is 25 millimeters per second. So the device will record 1 second of patient heart. That means it will consume 25 millimeters. 25 millimeters means 25 small squares, and that is equal to 5 large squares. So 1 square here, let me get in a pen, square 2, 3, 4, 5. So this length will be ejected in 1 second only. Okay, so 1 second is 25 millimeter. Okay, now the x-axis is always the time. Okay, how about the y-axis, the height? The height will be is actually the voltage, and the voltage sensitivity is set to 10 millimeter per millivolt. So if the heart is making 1 millivolt, which is really a huge amount of electricity, if the heart is making 1 millivolt, the amplitude of the wave will be 10 millimeters. It means 10 small squares or 2 large squares. Okay, this is the standard speed of the paper. Now, let's do some calculation. And these calculations are really important. Now, if we said like the speed of the paper is 25 millimeter per second. Okay, now what is the time for 1 square to be ejected? So again, guys, for 25 squares to be ejected from the device, we need 1 second, right? Per 1 second, the device will eject 25 millimeters or 25 small squares. So if I want to know the time for only one small square, what should I do? It's very easy. I will divide this second on 25 small squares. So when I say 1 divided by 25, it will be 0.04 seconds. So the time that the machine needs to eject 1 small square is 0.04 seconds. Now, we usually don't use seconds, we use milliseconds. And to convert from seconds to millisecond, we multiply by 1,000. So this number, if multiplied by 1,000, it will give you 40, right? So the small square means 40 milliseconds. All right. Now, what about the height? The height of 1 small square. Now, it's very easy. 1 millivolt will give you 10 millimeters, 10 small squares. So how about 1 small square only? So this 1 millivolt will be divided by the 10 small squares and will give you 0.1. So each small square is actually worth 1.1 millivolt. Okay? This is important. This number, especially the 40 milliseconds, should be memorized. So how about a large square? How much time we need to eject a large square? What's the duration of a large square? It's very easy, right? Why? Because each small square needs 40 milliseconds. So this needs 40, and this needs 40, needs 40, needs 40. So 40 multiplied by 5 will give you 200 milliseconds, or it's 0.2 second, because if you want to reverse your calculation from millisecond to second, you divide by 1,000. So 200 divided by 100 by 1,000 will give you 0.2 seconds. Okay. This number to be memorized, guys, the 0.04 seconds or 40 milliseconds. We will need this number when we talk about the criteria for EKG waves. Now, my second thing that I need you to know is something called calibration curve. The calibration curve, always, when the EKG is done, it will draw a calibration waves. Calibration wave, by definition, is 5 small squares width and 10 small squares height. That means this calibration curve needs 1 millivolt, right? Because 1 millivolt will give you 10 millimeters, which is 10 small squares. Okay, so this is very important to know, because when you look at the calibration curve, you will understand that if you see this, that is 5 small squares width and 10 small squares height, you will understand that this is a standard paper. Okay, why I'm talking about standard speed and voltage? Because sometimes you need to adjust this. For example, if a patient is severely tachycardic, that his heart is racing, let's say that his heart rate is 170 beats per minute. Okay. Now, if you are using the regular speed, all the QRS complexes or the heartbeats will be stacked together. Okay. So and you will not be able to read very well. So what should I do? I can speed in the paper. I can just make it faster, 2 times faster, and make it like 50 millimeter per second. That means in each second, 50 square will be ejected. So in this way, the paper will be fast enough to spread these QRS complexes along the paper. Okay, so you increase the speed of the paper. Okay, the same thing will happen if the patient has severely bradycardic. Let's say his heart rate is 30 or 20. Now, if the paper is set at the regular standard speed, these QRS complexes will be very wide apart, and you will consume paper uselessly. So what you should do, make the speed less, like 10 millimeters per second. So the paper ejection will be slower. This will just let the QRS complexes come in close proximity to each other. Okay, so generally speaking, a rule of thumb, if your heart rate is super fast, you have to speed in your paper ejection. If the heart rate is very super low, you should slower your speed ejection. Now, what about voltage? Let's assume that patient has severely hypertrophied heart. The heart is really enlarged and the muscle is really bulky. If the muscle is bulky, means that the heart is generating more electricity, right? So the heart may generate 2 millivolts. That will be 20 millimeters. So the QRS complexes will be huge. And sometimes when the needle is drawing the EKG, it will be just larger than the paper itself. And you will not be able to interpret because some of the paper, some of the drawing is out of the paper. So what we should do, we will decrease the criteria. So we can make like 5 millimeter per 1 millivolt. Okay, so if the heart is producing 2 millivolts, it will be only 10 millimeters. Okay, and vice versa. Let's say if the heart is fibrosed and there is severe fibrosis and previous MI, the heart is dying and is generating very small amount of electricity. So the QRS complexes will be very tiny, which make the interpretation very hard. What you should do, you increase your voltage criteria. So you make it 20 millimeters per 1 millivolt. So if the heart is producing only 0.5 millivolt, that means it will generate a 10 millimeter wave, which can be read easily, okay? So you can just change the settings in order to the clinical scenario you have. That's why you have to incorporate history and physical examination to the ECG interpretation. And thank you.